Start with non-Hodgkin lymphoma. Non-Hodgkin lymphoma, if you remember, it is mostly affecting the B cells, and it affects mostly multiple lymph nodes, right? So mainly B cells, it is affecting, but among the neoplasm of mature B cells, here Burkitt lymphoma, diffuse large B cell lymphoma, follicular lymphoma, mantle cell lymphoma, marginal zone lymphoma, primary central nervous system lymphoma, and only two T cells, that is adult T cell lymphoma and mycosis fungoidosis. In non-Hodgkin lymphoma, you will find the Waldeus ring, that is a lymphoid tissue which is present in the pharynx. There is a reactive lymphoma, actually it is reactive lymphadenopathy, that is apoptosis of B cells, B cell death that will lead to debris and formation of macrophages. Now let us start with Burkitt lymphoma. It is mainly seen in adolescents or young adults. Here the translocation is 814, that is the c-Myc gene with the heavy chain IgG. So the main thing is starry sky appearance. You can see here this is called as starry sky appearance. Starburst sheets of lymphocytes with tinglable body macrophages. These are tinglable body macrophages, and it is associated with Epstein-Barr virus. In children, you can see it is mostly endemic, especially in Africa. They present as mandible mass, whereas endemic form in Africa, whereas pelvic or abdominal in the case of sporadic form. Okay, next coming to diffuse B cell lymphoma. It is most common lymphoma is a diffuse B cell. It is seen usually in older adults, but sometimes 20% in children also. Here the mutation is BCL2, BCL6. Actually, it is a B cell lymphoma, most common B cell lymphoma. So markers are CD19, CD20. I remember like B cell lymphoma, BCL2, BCL6, but all remaining all have translocations. You can see here. So this is 814 translocation. This is BCL2, BCL6 mutation, most common non-Hodgkin lymphoma in adults. Next, follicular lymphoma, 65 years, most common adults, 1418 translocation of heavy chain 14 and BCL2 18. Actually, it is painless waxing and waning pain. Lymphadenopathy. BCL2 normally inhibits apoptosis. Actually, BCL2 is important for apoptosis, to inhibit the apoptosis. So if there is mutation in BCL2, you can understand it will start forming a mass. That's why it is a follicular lymphoma. Here there is a follicular mass. Here there is a diffuse whole B cell mass. Okay, there Burkitt lymphoma, you will see mass in a mandible in the endemic. If sporadic, you will see mass in a abdomen like that. Mantle cell lymphoma, mantle males, like that you can remember males. Okay, and here 1114 translocation, that is between cyclin D1 and heavy chain IgG. Here it is CD5 positive, and there is transition from G1 to S phase. I remember as SS5. Okay, so CD5 positive, G1 to S phase. It is very aggressive patient present with late stage disease and very poor prognosis. Next, coming to marginal zone lymphoma. It is often extranodal. It is seen in adults, 1118 translocation, associated with chronic inflammation like Sjögren syndrome, chronic gastritis, mild lymphoma, and may regress with H. pylori eradication. Primary central nervous system lymphoma. Here you can see this is a primary central nervous system. It's Epstein-Barr virus related, also associated with HIV. Right? Actually, it is considered an AIDS-defining illness. It has various presentation like confusion, memory loss, seizures, and also CNS mass. You can see here, often single enhancing lesion on MRI. Especially it is seen in immunocompromised patients. Needs to be distinguished from toxoplasmosis via CSF analysis or other lab tests you can do and find out whether it's central nervous system lymphoma or anything else. Now coming to mature T cells neoplasm. Adult T cell lymphoma, CD4 positive T cell malignancy caused by HTLV, that is RNA virus, associated with IV drug use, and treatment diagnosis anti-HTLV1 antibodies. Adults present with cutaneous lesions, common in Japan. So T cell Tokyo, how to remember this? T cell Tokyo, but this is the CD4 T positive. Okay, West Africa, Caribbean, and you can see lytic bone lesions and hypercalcemia. Next, mycosis fungoides Sézary syndrome. It is seen mostly in adults. This diagram you can see clearly. It is actually presenting with skin patches and different plaques. You can see here. It is also cutaneous T cell lymphoma, characterized by typical CD4 positive cells with cerebriform nuclei. This is important. Cerebriform nuclei and intraepidermal neoplastic cell aggregates. Poacher microabrus may progress to Sézary syndrome, T cell leukemia, widespread erythema, and malignant cells are present in the blood. Now coming to plasma cell disorders, actually here the monoclonal immunoglobulin are overproduced. In lab findings, you will see serum protein electrophoresis, free light chain assay. You will see the M spike. You can see here the spike of M in SPEP represent overproduction of monoclonal Ig, that is monoclonal immunoglobulin. For urine analysis, you can see 24-hour urine protein electrophoresis, detect light chain. Dipstick can only detect albumin, so it can't detect it. You can confirm it with bone marrow biopsy. Next, coming to multiple myeloma. Multiple myeloma is overproduction of IgG greater than IgA. So clinical features you can remember with CRAB, that is hypercalcemia, R for renal involvement, A for anemia, B for bone lytic lesion. Actually, you will see punched out bone lesions on X-ray. These are the punched out bone lesions on X-ray, and also in the peripheral blood cell, you will see Rolex formation. That is, RBCs are stacked like a poker chips. You can see, and in urine analysis, you can see Benz-Jones proteins. Okay, Benz-Jones proteinuria, and also you can see the clock phase chromatin. This is a clock phase chromatin with monoclonal plasma cells, and also intracytoplasmic inclusions containing IgG. Complications are increased infection risk and primary amyloidosis. I'll discuss about amyloidosis also. Primary amyloidosis is similar to almost like multiple myeloma. Okay, here the problem is that overproduction of IgG greater than IgA. Especially you can say light chains, increased light chains. So that is leading to renal damage, amyloidosis. And also TAM horsefall mucoprotein is present in the distal tubule. If anemia is present here, that will be normocytic normochromic anemia. Decreased erythropoietin due to renal failure. Okay. And next, coming to Waldenstrom macroglobulinemia. It's a B cell lymphoma. Here also there will be M spike from IgM. Here there will be problem of viscosity, increased viscosity that will lead to visual impairment and dizziness, headache. Medical emergency is emergent plasmapheresis. Actually, they have the overproduction of IgM. So, multiple myeloma, overproduction of mainly IgG. Here, IgM, Waldenstrom macroglobulinemia. In the name itself, you can understand macroglobin. Which globin? IgM globin. Okay, because IgM is actually the largest Ig. The largest immunoglobulin is IgM. That's why it is Waldenstrom macroglobulinemia. Okay, clinical features are peripheral neuropathy, but no CRAB findings, hyperviscosity syndrome, headache, blurry vision, Raynaud phenomena, that is hands become blue colored. Okay, and also you'll have retinal hemorrhages. Bone marrow analysis shows greater than 10 small lymphocytes with intranuclear pseudo-inclusions containing IgM, that is lymphoplasmacytic lymphoma. Complications is thrombosis. Next, coming to monoclonal gammopathy of undetermined significance. Here there is overproduction of any Ig type, that's why gammopathy. Okay, and it's usually again no CRAB findings. Analysis, bone marrow analysis less than 10% monoclonal plasma cells. Complication 1 to 2% risk of year transitioning to multiple myeloma. Detected with workup of anemia, hypercalcemia, and bone pain. Now coming to myelodysplastic syndrome. Myelodysplastic syndrome is actually a stem cell disorder involving ineffective hematopoiesis. Here actually there is not proper hematopoiesis, defect in cell maturation of non-lymphoid lineage, so that will lead to bone marrow blast caused by bone marrow blast will be less than 20%. Okay, it is caused by de novo mutations, environmental exposure like radiation, benzene, chemotherapy. Risk of transformation to acute myeloid leukemia, more common in older adults. So actually this is having chance to convert into acute myeloid leukemia. We'll discuss leukemias in next videos. So it is ineffective hematopoiesis, that is anemia, thrombocytopenia, neutropenia, all are decreased because it is affecting the stem cell. Okay, so pseudo Pelger-Huet anomaly is a neutrophil with bilobed nuclei. You can see the neutrophil with bilobed nuclei. It is associated with myelodysplastic syndrome or immunosuppressant drugs. Now coming to amyloidosis. Amyloidosis is divided into primary and secondary. Actually, it is nothing but aggregation of amyloid proteins in extracellular space. It is having amyloidosis means usually greater than 20 proteins are accumulating. Here Alzheimer's, beta amyloid, cerebral amyloid angiopathy, they are having beta amyloid. Type 2 diabetes, amyloid is present in pancreas. Diffuse amyloid deposition is nothing but amyloidosis. What is transthyretin? Transthyretin is actually which transports the thyroid and also retinol. It is mutant in hereditary amyloidosis. Hereditary amyloidosis, transthyretin is defective. Primary amyloidosis, I already said, it is same like plasma cell disease or malignancy. There are light chains accumulation. Treatment is stem cell transplantation. Amyloid will take up the Congo red stain and show apple green birefringence under polarized light, and it forms beta pleated sheets. Secondary amyloidosis is chronic inflammatory condition. Serum SAA protein is increased. Familial Mediterranean fever, it's a rare hereditary disease, involves the neutrophils, having recurrent fevers, inflammation, serosa inflammation, abdominal pain, pericarditis. Secondary amyloidosis, major cause of death. Treatment colchicine inhibits the neutrophils. Next, dialysis related amyloidosis is related to beta microglobulin, complication of renal failure, shoulder pain, carpal tunnel syndrome. So very important, carpal tunnel syndrome is related to dialysis related amyloidosis. Age related amyloidosis, wild type, normal transthyretin, greater than 70 years, common in heart diseases. Familial amyloidosis is a mutant transthyretin produced in liver, treatment liver transplant. Next, coming to skin. In skin, you see periorbital purpura, muscle and large trunk, normal peripheral neuropathy, liver hepatomegaly, bowel malabsorption, and blood vessel bleeding. Kidneys, most common organ, lead to proteinuria, nephrotic syndrome. In heart, restrictive myocardiopathy, diastolic heart failure, arrhythmia, sudden death. All these are complications due to amyloidosis, that is protein accumulation in extracellular space. Diagnosis is tissue infiltration of amyloid, abdominal fat bed preferred. Signs and symptoms, biopsy, if amyloid is positive, if primary amyloidosis, light chains, secondary amyloidosis, serum protein A, dialysis, beta 2 microglobulin, senile, transthyretin receptor, if it is hereditary also, transthyretin receptor. Now coming to leukemias, actually what are leukemias? That is more overgrowth and differentiation of WBCs in bone marrow that will lead to bone marrow failure and later anemia, that is decreased RBC, infection because decreased WBC, hemorrhage because decreased platelet, and usually present with increased WBC, that is malignant leukocytes in blood. So whenever you see more amount of WBC, suspect the leukemia, although some cases will present with normal or decreased WBC. Don't mean that always if you have high WBC that is leukemia. Sometimes with low WBC also you may have leukemia. So leukemic cell infiltration may go into liver, spleen, lymph nodes, skin, all this is possible. So actually it is a dangerous disease, it's like a cancer. Okay, so lymphoid neoplasm are acute lymphoblastic leukemia, chronic lymphoblastic leukemia, hairy cell leukemia. Let me see this. So first is acute lymphoblastic leukemia or lymphoma. Actually it is having bone pain, headache and vomiting. It is occurring mostly in children, less common in adults. Always remember acute means it is acting on the blastic cells. Always remember blastic cells are present in the bone marrow. So you can remember like that, blastic cells are precursor cells like small cells, so they are affecting the small children and it's acute condition. Okay, here the T cell acute lymphoblastic leukemia can present as mediastinal mass presenting as SVC like syndrome. It is associated also with Down syndrome because it's children, it is affected with Down syndrome, and also SVC like syndrome because sometimes mediastinal mass is also present. And the peripheral blood and bone marrow have increased lymphoblasts. You can see here, these are the lymphoblasts which are the precursor cell for white blood cells. So when these lymphoblasts are more, then you will say acute lymphoblastic leukemia. And the TDT positive marker of pre-T and pre-B cells, and also CD10 positive. CD10 positive means you know that it is a pre-marker for B cells, right? Pre-markers of T cells and B cells, actually they both are TDT positive. If they are CD10 positive, you can say B cell positive, and B cell positive are most common. If you remember, even in Hodgkin, non-Hodgkin lymphoma, B cells are most common, right? So most responsive to therapy may spread to CNS and also testis in small children. Okay, and here the mutation is T12 to 21. So this in children it is most common, that is TEL-AML1 mutation. So it is having better prognosis. But T922, that is the Philadelphia chromosome, have worse prognosis. It is mostly seen in adults. So in children you will see 1221. It is having better prognosis. How to remember this? I remember like 1 to reverse this 2-1. Okay, so if it is reversible, I remember it as better prognosis because it is reversible like that. Okay, 1221 seen in children, but 922 is very dangerous Philadelphia chromosome. How to remember this 922? I remember like time in clock. After 9, 10. In 10 you'll represent as 22, can represent 10 as 22, right? So like that I remember. Okay, Philadelphia chromosome, worst prognosis in adults. Now coming to chronic lymphocytic leukemia or small lymphocytic leukemia. If the lymphocyte is less than 5000, if lymphocyte is greater than 5000, increase single lymph node growth. Or if lymphocyte is less than 5000, actually here the age is greater than, I mean the small lymphocytic lymphoma means lymphocytes are less than 5000. Chronic lymphocytic leukemia means greater than 5000. Okay, so how to remember this? It is chronic, right? So it is seen in adults, and it is lymphocytic, not blastic. Blasts are present in bone marrow, lymphocytes are present in the blood vessels, right? So it is seen in adults. It's the most common adult leukemia, CD20, CD23 5 positive B cell neoplasm. So this is also B cell, often asymptomatic, slow smudge cells. So you can see smudge cells here. You can see this one. These are the smudge cells. So smudge cells, you can find that in chronic lymphocytic leukemia in peripheral blood smear. There's also autoimmune hemolytic anemia. If you remember autoimmune hemolytic anemia, either IgG or IgM may attack. Actually, WARM is most common, so IgG may attack on the blood cells, and that will lead to hemolysis and crushed little lymphocytes. How to remember this? You can see here CLL, that is chronic lymphocytic leukemia, crushed little lymphocytes, that is smudge cells. So like that you can remember. And there is hypogammaglobulinemia, that is IgG, IgA, IgM, all those are decreased. And this richer transformation, that CLL or SLL transformation into aggressive lymphoma, most commonly diffuse large B cell lymphoma. You know that diffuse large B cell lymphoma is a non-Hodgkin lymphoma, right? Here if you remember this, so this one, diffuse large B cell lymphoma. So actually that CLL, that is chronic lymphocytic leukemia, may become aggressive into diffuse large B cell lymphoma. Okay, so we have discussed the lymphomas of children and also adults, that is lymphoblastic and lymphocytic. Now hairy cell leukemia, it is most common in male. How to remember? Remember like male is somewhat more hairy than female. Okay, so it is a mature B cell. All these are B cells, mainly B cell tumors. So cells have filamentous hair-like projection, fuzzy appearance. So here you can see this is a fuzzy appearance around this blue. So there's a hair cell leukemia, and this causes mainly peripheral lymphadenopathy. Actually, peripheral lymphadenopathy is uncommon here. It causes marrow fibrosis, dry tap and aspiration. Patients usually present with massive splenomegaly, especially the red pulp is enlarged, and pancytopenia. Because if you see the bone marrow, it is completely fibrous. If bone marrow is fibrous, then it can't produce any cells, blood cells. So bone marrow suppression. Stains trap. So remember this trap, that is trapped in hairy situation. How to remember this? It is largely replaced with flow cytometry associated with BRAF mutations. Treatment purinolones like cladibrin and pentostatin. Begin with myeloid neoplasms. So myeloid means you know that lymphoid precursors will form T cells and B cells. So here the neoplasm is in the myeloid cells. So actually they can, myeloid cells can form granulocytes like BEN, that is basophils, eosinophils, neutrophils. They can also form platelets, they can also form RBC. So many types of blood cells can be formed from myelocytes. So if there is neoplasm in this condition, you can understand in the case of acute myelogenous leukemia, you may have problems of all these cells. Even in chronic myelogenous leukemia, you may have all these problems like related to granulocytes, platelets, RBCs, everything. Okay, so acute myelogenous leukemia is actually interesting factor about this is it is having or rods. It is a characteristic factor or rods. Here in this diagram you can clearly see these are the or rods which are present especially in acute myelogenous leukemia. They are myeloperoxidase positive, and they show the cytoplasmic inclusions mostly in APL, that is formerly M3 AML, increased circulating myeloblasts on peripheral smear. So in the peripheral smear will mainly observe increased amount of myeloblasts, and they may be present with leukostasis, that is capillary occlusion by malignant non-distensible cells, and that is leading to organ damage. Actually, this leukemia can go and obstruct the blood vessels, and that will lead to that specific organ damage because of ischemia. The risk factors are prior exposure to alkylating chemotherapy, radiation, benzene, and also different myeloproliferative disorders, even Down syndrome, typically acute myeloblastic leukemia. Formally, it is called M7 AML, and also APL-T1517. That is a translocation of 1517. Response to all trans retinoic acid vitamin A, and also to arsenic trioxide, which include differentiation of promyelocytes. And DIC is a common presentation here, because here, although the platelets are increased, all the platelets are going to form a clot, and some other platelets are going to as everything are going and forming a clot, there are less amount of platelets, so it is also leading to bleeding at the same time. That is called as DIC. Here, chromosome 17 is affected in the case of vitamin A, and or rods are common. So you can see here there is a bone marrow suppression. Of course, because from the bone marrow only all these myelocytes are forming. So in acute myelogenous leukemia, there is bone marrow suppression. Myeloperoxidase positive. Key subtype is APML. So APML is a fusion gene where there is translocation between PML and RA mutation here. So it is APML. It is a subtype. Now coming to chronic myelogenous leukemia. Actually here I can see it in 45 to 85 years age. Median age is 64 years. It is mainly due to Philadelphia chromosome. That is a translocation between 9 and 22, and BCR ABL. So it is a myeloid stem proliferation. It is presenting with dysregulated production of mature and maturing both, like mature granulocytes that are already like in the blood, and maturing granulocytes like they are still in a blast form in the bone marrow. So neutrophils, metamyelocytes, myelocytes, basophils, all are affected. Here you can see these are the basophils, and also there will be of course splenomegaly, and this will accelerate and transform to either acute myelogenous leukemia or acute lymphocytic leukemia, that is blast crisis. So it is responding to BCR ABL tyrosine kinase inhibitors, that is imatinib. So this T922 synthesis tyrosine kinase. So treatment is tyrosine kinase inhibitor. So in Philadelphia chromosome translocation, the treatment is tyrosine kinase inhibitors, because they are having the capability to produce a tyrosine kinase. So if we inhibit them, it is nothing but we are inhibiting this chronic myelogenous leukemia. Now coming to chronic myeloid leukemia. As I said, there are granulocytes. There will be essential thrombocytosis, that is the platelets will be increased. Polycythemia vera means RBC also increase. Okay, so myeloproliferative neoplasm is nothing but like it is a proliferative neoplasm of the bone marrow, where the bone marrow is completely fibrosed. Actually, it is especially myelofibrosis. Bone marrow is fibrosed so that it can't form any more cells, and it's like bone marrow cries because it's fibrosed. So if it cries, it forms a tear cells, that is a dacrocytes of RBCs. You can see here. Okay, next coming to polycythemia vera. Actually, here there is a JAK2 mutation. It's a hypersensitive to cytokines. There will be increased hematocrit, because polycythemia vera means increase RBC and also increase hemoglobin. Okay. So this may progress further to myelofibrosis, AML, CML, gout. Gout also because increased DNA turnover, and that will lead to increased purines, and that will lead to accumulation of uric acid. But one thing you need to remember here is in the polycythemia vera, there is decreased erythropoietin, because already there are a lot of RBCs in the circulation, so erythropoietin will drop. But in the case of secondary polycythemia, that is because first the erythropoietin is increased, and because of increase in erythropoietin, RBC are increased. That is especially in the conditions like hypoxia, and whenever there's renal cell carcinoma, the EPO will increase. As erythropoietin is increased, now there's polycythemia. Essential thrombocythemia means thrombocytes are increased, especially platelets. Here also there is JAK2 mutation. In this diagram, you can see this is actually a massive proliferation of megakaryocyte. That is a blood smear showing increased number of platelets, large or abnormally formed platelets. These are the abnormally formed platelets. So because of this essential thrombocythemia, there may be bleeding if the platelets are dropped. There may be thrombosis if the platelets are more. In polycythemia 1, where one or associated condition is there will be itching after the shower, that is called as aquagenic pruritus. This is because of increase in number of RBCs, and also there will be erythromelalgia, that is severe burning pain and red blue coloration due to episodic blood clots in the vessel of extremities. Why blood clots are forming? Because of more RBC. And also it is associated with hyperviscosity and thrombosis, so it may lead to pulmonary embolism, DVT, and also Budd-Chiari syndrome. You know Budd-Chiari syndrome, there's a blockage in the venous system of a liver. Okay, now coming to the treatment for polycythemia, whether that is phlebotomy, hydroxyurea, or ruxolitinib. And one more thing, in the case of myelofibrosis, is there will be dry bone marrow tap, because bone marrow got fibrosed. And the secondary causes of myelofibrosis may be polycythemia vera. Here the RBCs are increased, even WBCs are increased and platelets are increased, but there is no Philadelphia chromosome, but there are JAK2 mutations, because it is due to JAK2 mutations. Essential thrombocythemia, in the name itself you can see only platelets are increased, and here JAK mutations are present but only 30 to 50%. Next, coming to myelofibrosis, as I said, the bone marrow will get fibrosed, so no RBC, no WBC, no platelets, and Philadelphia chromosome is negative. Here also there is JAK2 mutation but 30 to 50%. Now comes to CML, that is chronic myelogenous leukemia. In this condition, RBCs are dropped, WBCs are increased, platelets are increased. Philadelphia chromosome is positive here, because CML is mainly due to Philadelphia chromosome, but JAK2 mutations are not present. Very important thing in chronic myelogenous leukemia, RBC is dropped, whereas WBC platelets are increased. Now let us see leukemoid reaction versus chronic myelogenous leukemia. Actually, leukemoid reaction, it is a reactive neutrophilia. Neutrophils are more, that is greater than 50,000. In chronic myelogenous leukemia, there is myeloproliferative neoplasm, which is positive for BCR-ABL. BCR-ABL is nothing but Philadelphia chromosome. Okay, and here the neutrophil morphology is toxic granulation, that is Dole bodies. If you remember, Dole bodies are double nucleated neutrophils with cytoplasmic vacuoles. But here they are pseudo-Pelger-Hewitt anomaly. So this Hewitt anatomy is also nothing but like a double nucleus. Sorry, Dole bodies means not double nuclei, bilobe nuclei. Bilobe nuclei, that is Hewitt for duet. How to remember this? Hewitt, duet nuclei in the neutrophils. Okay, that is pseudo-Pelger-Hewitt anomaly. Next, coming to lab score. Lab score is increase in leukemoid reaction, that is a left shift increase bands and neutrophils, whereas lab score is decrease in malignant neutrophils, is decrease in chronic myelogenous leukemia. Eosinophils and basophils are normal. Here eosinophils and basophils are also increased in chronic myelogenous leukemia. If you remember, I said all WBCs are increased, so eosinophils and basophils are also increased. Here eosinophils and basophils are normal. Now coming to polycythemia. In polycythemia, let us see the lab values. So related to polycythemia, there will be decreased plasma volume, whereas RBC mass, oxygen saturation, and EPO levels are normal. Association, you can see this in dehydration and burns. So in dehydration and burns, only plasma volume is decreased, but RBC, oxygen saturation, EPO, all those are normal. Coming to appropriate or absolute polycythemia. So in absolute polycythemia means what? Increase in RBC. So here RBC mass will be increased, oxygen saturation will be decreased even though RBC mass is increased. EPO levels, as the EPO levels are increased, only RBC is increasing. EPO is nothing but erythropoietin. So here the association is a lung disease, congenital heart disease, and high altitude obstructive sleep apnea. So in all these conditions, you can understand the oxygen saturation is decreased, especially lung disease, in some congenital heart disease, and high altitude obstructive sleep apnea. Here the oxygen saturation is decreased. As oxygen saturation is increased, the EPO is increased. Because EPO is increased, RBC is increased. Now coming to inappropriate absolute. Inappropriate absolute means here only the EPO is increasing, but all these are not increasing, they are normal, so it is for sure inappropriate. So it is seen in the case of exogenous EPO, only you are giving exogenous EPO in athlete misuse, or also called as blood doping. So blood doping is athlete misuse, where they are taking exogenously high EPO, even though they are taking high EPO, the plasma volume, RBC, oxygen saturation, all are normal. And also it is seen in androgen supplementation, and inappropriate EPO secretion is seen in the case of malignancies like renal cell carcinoma and HCC. So here only EPO is rising. Now coming to, sorry, as EPO is rising, even the RBC mass is rising. Here it's not visible. RBC mass is also rising. EPO is rising. RBC mass is also rising. Next, coming to polycythemia vera. Here the plasma volume is rising, RBC mass is rising, but EPO is decreased. Why EPO is decreased? Because already there is lot of RBC because of polycythemia vera. In the cases like we are seeing chronic myeloid leukemia, in the conditions, of course in chronic myeloid leukemia RBC will not rise. In some other leukemias RBC may rise. As already RBC has rise, EPO levels drop because already there's lot of RBC, so no need to rise EPO. So EPO dropped in PCA due to negative feedback suppressing from renal EPO production. Let us see chromosomal translocations. So if there is translocation of 8 and 14, T8, 14, that is Burkitt lymphoma, c-MYC activation. If 11, 14 translocation, that is mantle cell lymphoma, cyclin driven activation. 11, 18 translocation, marginal zone lymphoma. 14, 18 translocation, follicular lymphoma, that is BCL2 activation. And if there is 15, 17 translocation, that is APL, formerly M3 type of AML. And next, if there is 922, that is a Philadelphia chromosome. Here there is CML, associated disorder is chronic myelogenous leukemia, and also acute lymphocytic leukemia. This is less common. And Philadelphia chromosome, you can remember like cream cheese, cream ML, then CML. Next, coming to Langerhans cell histiocytosis. Actually, this is a proliferation of dendritic cells, which are the cells which are mostly present in skin and also involving the bone. So in children especially, they can see bone lytic lesions like this, and also child may present with a skin rash or recurrent otitis media with a mass involving mastoid bone. And these cells are functionally immature and they do not effectively stimulate primary T cells. So these cells express S100 and also BCD1A, S100 and CD1A, Birbeck granules. So these are the Birbeck granules. You can see they are like a tennis racket or rod shaped, and these are characteristic for the Langerhans cell histiocytosis. So clinical features are letter sieve disease, that is in child, there's diffuse skin rash, cystic bone lesion, and also multisystem failure, which is rapidly fatal. And this eosinophilic granuloma, that is in adolescents, there's no skin involvement, there's pathological bone fracture, there is not osteosarcoma, and they have Langerhans cells or eosinophils. Next, coming to Hansch color Christian disease. This is a triad with skull, diabetes insipidus, and exophthalmos, and also scalp lesion, and also post pituitary diabetes insipidus, and also there is protrusion of eye. This is posterior pituitary. So all these are related to this. Next, finally coming to tumor lysis syndrome. So tumor lysis syndrome is actually seen in a patient's, especially it's an oncological emergency, which is triggered because of massive treatment of cancers. Because if you treat cancers, they start to break down. As they break down, you can understand they can release many ions. Like if they release potassium, that will lead to hyperkalemia, and if they release more phosphate, that will lead to hyperphosphatemia, and also hypocalcemia due to calcium sequestration by phosphate, and increased nucleic acid breakdown, that will lead to hyperuricemia, and this acute kidney injury. So prevention and treatment include aggressive hydration, allopurinol, and also RAS uricase. So you can see here tumor lysis syndrome, there's excessive potassium, low calcium because it is sequestrated with phosphate, high phosphate, and high uric acid. High uric acid lead to uric acid crystals, that will lead to acute kidney injury. High phosphate, calcium phosphate crystals, again acute kidney injury. Low calcium will lead to ECG changes, seizures, and also tetany. High potassium will lead to muscle weakness. Okay, and also high potassium will lead to erythema. So this is a tumor lysis syndrome. So by this we handle hematology and oncology. Next we'll